Welcome back to Clot Conversations, the podcast where we cover some of the latest work in the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm thrilled to be joined once again by my co-host, Dr. Jamil Abdulrahman from Toronto General Hospital and Dr. Mahal Othman from Queen's University in Kingston. Get ready for another insightful discussion where today we delve into the pediatric world. Thank you for being a listener.
In this episode, we will be discussing a publication covering recent research from the Journal of Blood entitled Long-Term Outcomes of Pulmonary Embolism in Children and Adolescents. We're pleased to have two of the authors join us today, Dr. Laura Avila and nurse practitioner Jennifer Vincelli.
Dr. Laura Avila is a clinician scientist at the Child Health Evaluative Sciences Program Research Institute at the Hospital for Sick Children in Toronto. She leads a research program in long-term complications of thrombotic events in pediatrics. Her research interests are focused on measurement in medicine and outcome assessment. And Jennifer Vincelli, who also works at the Hospital for Sick Children, is a certified pediatric hematology oncology nurse. She is also an adjunct lecturer at the University of Toronto Lawrence Bloomberg Faculty of Nursing. Great to have you both here today, and thank you for participating in our podcast. Let's get started.
So maybe we'll start with, since some of our listeners may not be too familiar with pediatrics, when is VTE in the pediatric population, and what was the motivation to conduct this study?
Yeah, thanks, Jamil. We know that VTE is a rare disease in the pediatric population compared with adults. The frequency of detection of VTE, though, is increasing, particularly in tertiary and quaternary centers. A 300% increase in the frequency of VTE was reported between 2001 and 2019. When we look at pulmonary embolism as a subset, approximately 10% of these are VTE cases in children. In the adult group, 50% of adults with PE have been reported to have long-term complications. The frequency of these complications in children, however, is unclear. And that was primarily our motivation, to have a look at the frequency of long-term outcomes among patients followed up at sick kids who have had PE.
So you conducted a single-center prospective cohort study following pediatric participants with acute PE who survived at least 6 months post-PE diagnosis. We're curious to know what are the outcomes that you were looking for following these participants.
Thank you for the question. So essentially, we were looking for what we call the regular outcomes that are reported in many of the pediatric studies, which is PE resolution, PT recurrence, and death. But we also wanted to add into that the functional outcomes for which we had and no data or very little data, scattered data before. So in 2004, we implemented a follow-up protocol at CTEPH in our thrombosis clinic, and that protocol encompassed doing clinical assessments, pulmonary function tests, exercise testing, and echocardiograms, in addition to the regular CTEPH or lung imaging follow-up for these patients. And in there, we took all those results to report on the functional outcomes that included the presence of dyspnea, abnormal PFTs or pulmonary function test, abnormal echocardiograms, impaired aerobic capacity, and the whole umbrella of post-PE syndrome as defined in the adult population, which includes chronic thromboembolic pulmonary disease, CTEPH or chronic thromboembolic pulmonary hypertension, post-PE cardiac impairment, and post-PE functional impairment after anticoagulation for at least 3 months, in the absence of other comorbidities that can explain clinical findings. And that's an important key because we'll go over the results later, but and the fact that we were looking whether there was another explanation for those clinical findings as well to define the umbrella of post-PE syndrome.
Okay, so in the end, you included 150 participants in the study. Could you give us a breakdown of who these participants were?
Our participants were largely teenagers at the time of diagnosis of pulmonary embolism. The median age at the time of PE was 16 years. 2/3 of our patient cohort had an underlying condition. These included autoimmune conditions, cancer, infectious diseases, and cardiac complications. Most patients, around 83%, had a low-risk PE at the time of diagnosis. And concomitant DVT was found in about 55% of our patients. 1/3 of those had a central venous catheter at the time of DVT diagnosis.
Thank you. So now we would like to know the outcomes. What did you find regarding particularly the PE resolution, the VTE recurrence, and mortality?
We found the regular outcomes, let's call it that way. The lack of resolution was documented in about a third of the patients. 70% of the patients had a PE resolution on follow-up. That's about 3 months to 6 months after the initial PE. We saw VTE recurrence, so new thrombotic events after the initial PE in about 10% of the patients. At a median, also about 3 months after the initial event, but sometimes a little bit later. And we included patients that survived the first 6 months to see long-term follow-up. So some of the patients died early on. They were not included in the cohort, but the mortality that we saw in the long term of these 150 patients was about 5%. So that's the common outcomes for these patients. And death on these patients, most of them died of their underlying condition. There's only one patient that died of unknown causes. For the most part, they died of their underlying condition.
Okay, can you tell us about the functional outcomes?
In terms of dyspnea, we saw dyspnea present in about a quarter of the patients, 26% to be precise. The important bit is that of those patients, 3 months after or 6 months after they reported some dyspnea, but being chronic, meaning that being present in at least 2 assessments 4 weeks apart, was much lower, 7%, and only 1% of the patients had dyspnea without any other explanation. So the possibility that PE is behind the dyspnea was very low, only 1%. That's one side. The other part is the echocardiogram findings. We found that about 11% of the patients had abnormal echocardiogram findings like right ventricle dysfunction or dilation, but only 4% were chronic, also seen in subsequent echocardiograms, and only 3.5% or like roughly 4% had no other explanation for those findings. Now, one of the findings that was the most common finding possibly was the impaired aerobic capacity in cardiopulmonary exercise and testing, or CTEPH, was seen in about a third of the patients, 31% of the patients, and was much lower, or it was more frequent, or the Z-scores for VO2 peak was lower in patients with underlying conditions. So those patients were more affected. We saw some changes in the pulmonary function test with some abnormal ventilatory patterns, also more frequent in patients with underlying conditions, which again was 2/3 of the population. So those patients seem to have, maybe those impairments are related to their underlying condition, but to the point to which P may contribute to that, we don't know. So that indicates that we need to follow up these patients closely and be aware of these potential additional outcomes. In terms of the whole umbrella of post-PE syndrome, CTEPH was only seen in one patient for an incidence of 0.7%. Post-PE cardiac impairment, so echocardiogram findings plus dyspnea, only one patient, 0.7%. And post-PE functional impairment, which is abnormal aerobic capacity and dyspnea, in about 9% of the patients. So again, impaired aerobic capacity, with deconditioning being one of the most common reasons for that impaired capacity, was the most common finding. And again, most common in patients with underlying conditions, not patients without underlying conditions, which was a third of the population.
Thank you for this. I'm wondering, how did your findings, these findings that you just explained, compare to other studies looking at long-term outcomes post-PE in pediatric populations? And I know you mentioned that there's only little in literature.
Yeah, so the common or the regular outcomes about resolution, death, and thrombosis recurrence were similar to what's published in the pediatric literature. It wasn't too different. The mortality was a little bit low, depending on the study that you looked at, but that's again because we didn't include patients who died up front. We only included patients that had long-term follow-up. Then we compare the studies and our results to the studies in adult patients, and we found that the frequency of dyspnea is around a little bit lower, depending on the study you look into or the results you analyze, as compared to adult patients. The number of patients with abnormal ventricular patterns was also similar to what might be seen in some adult studies. Echocardiogram findings also very similar. What is much, much lower is the frequency of post-PE syndrome. So in the literature, in adult patients, about maybe 50% of, depending on how you define post-PE syndrome, but maybe up to 50% of patients may have some outcomes or findings that are resembling post-PE syndrome in our patients. Once you exclude every other reason for that can explain those clinical manifestations, so going to the current definition of post-PE syndrome was much lower, less than 1% for CTEPH, less than 1% for post-PE cardiac impairment, and about 8 to 9% for post-PE functional impairment. So much lower. And again, it's deconditioning what we see in most of these patients, which is great news for our patients. That's the main point. This is great news for our patients. And when the study came out, and that was one of the things that was highlighted, that this is great news for our patients.
We hope it'll help reduce a little bit of anxiety associated around a diagnosis of PE. And we know that there are some interventions that we can implement to hopefully help them overcome the challenges they may face.
Excellent. Thank you.
Hey, so you alluded to this a bit, but 20 to 30% of children with PE having long-term abnormal function findings. How can we improve on this? Do we need to be more aggressive with anticoagulation, more focused on functional testing, implement treatment strategies to help manage symptoms? Where do we go from here?
I think in general in pediatrics, we're pretty aggressive upfront with anticoagulation management. Our goal is to achieve full clot resolution whenever possible. We do think that there is some utility in implementing some strategies as it relates to exercise medicine to help improve conditioning and muscle strength and endurance and that sort of thing. So we've teamed up with our exercise medicine program here at the hospital. And for patients that we identify early on who might be at risk for some of these outcomes, we try to implement some intervention early on to help negate a lot of these potential factors.
And we are quite protective of our kids in the sense that we instruct them not to do when they get started on anticoagulation. We tell them what not to do. And one of our patients in another study, they were mentioning that we tell them what not to do, but we don't tell them what to do. So now we have a list of activities that can be implemented early on. So for the first 4 weeks, maybe activities of daily living, and then slowly ramp up in terms of physical activity. And we give them a list of things that they can do while they're on anticoagulation instead of just telling them what not to do. We try to include advice that they can act on and take for their own life and keep going back into physical activity to undo the deconditioning we create by telling them to just rest for the first few weeks until they heal. We're just trying to say what they can do as well, or counsel what they can do as well.
Thank you so much for all of this. I think you covered really nicely this elegant study, but we're wondering, was there anything else that we haven't discussed that you would like to add?
Just reemphasize in the main point A that at least that's what we see in our population, at least at sick kids, this is what we see, that the frequency of long-term outcomes is really low in this population. And that's something that we use with patients in counseling to try to curb a little bit the anxiety of getting PE or getting another PE long term, that the risk of having long-term complications is somehow low or lower, at least that in adult patients, and that the condition is the thing that we see the most. So going back into physical activity is very important. And as pediatric treaters, we try to counsel about healthy lifestyle as much as we can, because we know these kids had an event already as young in their lives, and they need to grow older with those veins and arteries that maybe have some impact on because of the thrombotic event. And emphasizing healthy lifestyle, we think is going to go a long way for them.
Exercise, no cigarette smoking, all those sorts of things that we would inform anyone about, healthy diet, etc.
For sure. Thank you so much for covering this, and we enjoyed speaking with both of you.
Thank you for having us.
Yeah, thank you both. It's great to have you on the podcast, and we appreciate the information about your study that you've shared with us today. And for our listeners to read the full publication, we will provide the link in the program notes. And thank you to our audience for joining us on Clot Conversations. We love hearing from you. So send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. and follow us so that you get future episodes. This is our 46th episode, including a great collection of discussions from the recent ISTH meeting with Canadian researchers that you may want to check out. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, information on our annual conference coming up this fall. Your support matters. Consider donating to Thrombosis Canada to help us continue the fight against thrombosis. Thank you all.